Okay, diagnosing STEMI in patient with right bundle branch lock. And I must say that for years, we have been told that it is very difficult to diagnose myocardial infarction or STEMI in patient with left bundle branch lock. However, right bundle branch lock does not interfere with the repolarization, and therefore people with right bundle branch lock can undergo regular stress testing, ECG stress testing, and it's not a problem to diagnose myocardial infarction, but there is a shift. So the right bundle branch lock, the right bundle branch receives its blood supply from the anterior septal branch of the LAD alone or jointly with the AV nodal artery. Proximal LAD occlusion can result in new right bundle branch lock, which is often accompanied by left anterior fascicular block, left axis deviation, because the right bundle and the left anterior fascicle receive essentially the same blood supply. These types of intraventricular blocks are mostly reversible with reperfusion therapy. Now, this is a case of a patient with anterior MI. We see ST elevation in 1 AVL, lead V1 to V4. There is right bundle branch. There is a reciprocal change in the inferior leads. There is, as I said, right bundle with left axis. This is a typical case of this is where of proximal LAD occlusion. This is a dreadful sign. We need to recognize it and know that it is a proximal LAD occlusion. Transient right bundle branch lock in inferior STEMI is rare. It can probably be explained, at least in some cases, by ischemia of the proximal His bundle, selectively inhibiting conduction to the right bundle branch. The His bundle has dual supply by the AV nodal branch, proximal His bundle, and the first septal branch of the LAD, distal His bundle. However, right bundle can also be unknown previously, depending on rate or stretching of the right ventricle, and may not be a specific sign. This is, for example, an example of a patient with inferior STEMI with right bundle branch lock. And here we have a problem that we don't know if the ST depression in V1 to V3 is part of the right bundle branch lock or part of the more lateral extension. Left main infarct can also cause a right bundle branch lock in left anterior. This is an ECG sample from Miguel Fiol from Palma de Mallorca, who described a patient that had right bundle, left anterior, a lot of PVCs, ST segment elevation in the anterior leads due to left main acute occlusion. Left posterior hemiblock with right bundle branch lock is relatively rare. First, it should be differentiated from right axis deviation due to QS wave in 1 and AVL due to proximal LAD occlusion. But here we see a small R wave and then a wide S wave. So this is a left posterior hemiblock with right bundle branch lock. We don't have any specific anatomy to explain it. So the rest of the presentation is based on an editorial that we wrote in the Journal of Electrocardiology this year. Is right bundle branch lock the new left bundle branch lock? Are we going to repeat the same mistake? And when I say it, I mean that it was obvious that it is very difficult to diagnose STEMI, ST elevation, in patients with left bundle branch lock. And the famous meta-analysis from 1995 on patients that underwent reperfusion therapy suggested that thrombolysis therapy may benefit people with bundle branch block. The original paper did not differentiate between left and right, but somehow this meta-analysis was interpreted in the guideline, both the European and the American guideline, as indication for thrombolytic therapy in left bundle branch block. So it was class 1 indication until more and more study came, and actually the most recent guidelines say that left bundle branch block is usually not STEMI equivalent, which means an acute obstruction of a coronary artery. So complete right bundle branch block is commonly found in the general healthy population, about 1.4% in men, 0.5% in women. Possible causes include trauma, infiltrative disease, degenerative diseases of the conduction system, structural changes, inflammation, and myocardial infarction. However, a large percentage of individuals with right bundle branch block have no clinical evidence of structural heart disease or coronary artery disease. Over the years, there have been conflicting data on the long-term prognostic significance of right bundle branch block in individuals without overt cardiac disease. And it seems that after adjusting for age and other risk factors, isolated right bundle branch block is not independently associated with bad outcome. However, some studies suggested that when associated with left anterior hemiblock or left posterior hemiblock, right bundle branch block is a predictor of mortality. So possible explanation for poor outcome seen in patients with right bundle branch block, in stable patient, not in the context of acute coronary syndrome. Patients with RBBB have more LAD disease or concomitant disease. This is for patient with acute myocardial infarction. So patient with RBBB may have more concomitant LAD disease or proximal LAD as a culprit artery. They have more diffuse coronary artery disease. They may have larger infarct leading to pressure or volume overload, stretching the right ventricle and causing RBBB. RBBB is a surrogate marker of older age, higher risk factors, and therefore older people die more. And certain form of STEMI, anterior and infralateral, are missed in patients with right bundle branch block, and then I'll continue to talk about it. So it is commonly believed, as I said, that RBBB does not interfere with the diagnosis of STEMI. And therefore, in the guideline, there is no change in the criteria how to diagnose STEMI in patients with right bundle branch block. Now, the problem is, as I said and showed you already, that people with right bundle branch block tend to have ST depression in V1 to V3. How to diagnose STEMI in these patients, we don't have a clue. So this is a patient with inferior STEMI. We see ST elevation in the inferior lead, reciprocal ST depression in 1 and AVL, and there is ST segment depression in the anterolateral lead, and we don't know if this is part of this infralateral that used to be called posterior infarction in the past, or this is part of the right bundle branch block. Here is a patient, it's tricky, because in the inferior leads, there are only key wave inversion and not enough ST to call it STEMI. Yet there is significant ST depression, horizontal ST depression anteriorly. That is it infralateral STEMI equivalent due to circumflex or proximal RCA occlusion, or is it non-specific finding related to the RBBB. And this is again a patient with RBBB, left axis deviation, and there is ST segment depression anteriorly with T-wave inversion, part of the usual right bundle branch look. So we have a problem here. Can it be that a lot of patients presenting like this, we are missing STEMI with them? And after the troponin come up positive, nobody dare to call it STEMI later on because it will have a problem with our door to balloon time statistics. Now, another patient. This is another patient with right bundle branch lock, left anterior hemiblock, maybe LVH, RBBB, and a bit of ST depression in V2. Is it infarction? And when we compare it to the previous ECG, the lower one, we see that this is a new ST depression and T-wave inversion. So STEMI could have been missed without comparing it to the previous ECG. And what about when we have typical symptom or atypical symptoms that may be compatible with STEMI, and we have right bundle branch lock, and we have either electric ST or a little bit of ST elevation in the anterior lead? If usually we find ST depression in V1 to V3 in patient with right bundle branch lock, should we change the threshold for diagnosing STEMI on those patients? I don't know why my computer has a life of its own today. This is another example of right bundle branch lock with minimal ST segment elevation in the anterior leads. Is it STEMI? So reading those ECG offline without seeing the patient is very difficult. Yeah. So what about incomplete right bundle branch lock? We have here ST segment elevation in the inferior lead. We have here ST depression here. What criteria should we use for incomplete right bundle branch lock in the same setting? Is it STEMI? So the association of right bundle branch lock, at least pre-existing, and acute myocardial infarction most likely represent a more extensive coronary disease or more extensive comorbidities. On the other hand, development of new onset RBBB in a patient with STEMI, and especially anterior STEMI, could have completely different implications. This is a high-risk patient. The reported finding of lower survival, particularly in the early post-infarction phase, is an observation that merit further scrutiny. Currently, there is no sufficient data for the recommendation in the new European guideline for STEMI to activate primary PCI protocol for patients presenting with symptom and RBBB without significant ST elevation or deviation. However, if symptom persists despite initial medical therapy, urgent coronary angiography is warranted, as for all patients with ongoing symptoms. Thank you. Any questions?
Thank you very much, Dr. Birnbaum. And now I'd like to open the floor to any questions for Dr. Birnbaum.